It's my great pleasure to introduce my colleague here at the University of Wisconsin-Madison, Dr. Sterling Johnson. Dr. Johnson is a professor of medicine here in the Division of Geriatrics. He's a clinical neuropsychologist and really a world leader in Alzheimer's disease imaging and preclinical disease. And so as we heard this morning about the importance of identifying early brain changes before treatments can begin, Dr. Johnson will talk about some of the work that he and his team is doing here at University of Wisconsin. So welcome, Dr. Sterling Johnson.
Thanks, Cindy. Thank you, Cindy, and thank you, Sanjay, and the organizing committee for inviting me to present here. It's an honor to present among the distinguished speakers that we've had, and I hope I can contribute to what we're talking about today. I'll be focusing on preclinical Alzheimer's disease, and as we heard from the last speaker, this is really, and the last two speakers, this is likely where the action is and potentially where we can make some therapeutic impact. I've got a couple of pictures here on my opening slide. One is a tau image, and the other is a vascular image. And of course, we know that tau is critical to the phenomenon of dementia related to Alzheimer's disease. But it could be that the vasculature plays a role as well, and I'll be digging into that a little bit as we go along. So we've seen some slides like this. This is just some intro to motivate the problem. But I want to focus on the numbers down here at the bottom. There's 110,000 people or 115,000 people, depending on the estimates, in Wisconsin right now that have dementia due to AD. And we spend in Wisconsin alone $700 million annually in Medicaid dollars fighting this disease and treating this disease. Most of those dollars are spent in nursing homes where the disease has already taken its devastating course. So we'll try to prevent that. That's the goal of our center as a whole and our research collective as a whole. I'll be talking about our risk cohorts that we use, the RAP cohort, the Wisconsin Registry for Alzheimer's Prevention, and our IMPACT cohort, where we're investigating causes and treatments of memory impairment. And we'll focus on biomarkers of AD, particularly the molecular imaging biomarkers and how those correspond to CSF markers, and then the role of vascular changes. So here's the familiar framework where we see dementia diverting from normal aging, and the trick for us will be, we're very good at diagnosing dementia. We're very good at detecting mild cognitive impairment. The trick for us will be to detect this disease at the pre-symptomatic time frame, back here when one is cognitively still very much normal. Let's see, so if we could do that, we could, if we could identify the disease and potentially postpone the disease onset by 10 years, it would translate into a 75% reduction in the number of cases of AD. And obviously, that would be a pleasant state of affairs. So what do we know about preclinical AD? The field has been studying risk factors for the last 20 years or so. ApoE and age are the most dominant risk factors for this disease. And if you are a 65-year-old, you have a 10% LTR lifetime risk, approximately 10% of getting Alzheimer's disease dementia by the end of your life. At age 85, you have a 40% lifetime risk, 40 to 50%. We also know that women have this disease twice as often as men. We know that ApoE, if you're heterozygous, your risk goes up 2 to 3 times. If you're homozygous for E4, your risk goes up about 6 or 7 times. And so, and with parental family history, your risk goes up about 2 to 3 times, 2.5 times. And that would mean that at age 65, if you have a 10% lifetime risk, that your risk goes up to 25%. In the other column here, I've got a number of modifiable risk factors for Alzheimer's disease and other dementias, and these are mostly in the realm of lifestyle and things that may be treatable socioeconomic status is your access to health care and your access to equitable health care, your mood, your sleep, your diet, your cardiovascular health. All of these things may confer some kind of resilience. Whether that is a general phenomenon, a general brain resilience phenomenon, or whether it actually modifies the effect of amyloid or prevents the effect of amyloid in the brain is something we just don't know. So the cohorts that we've been cultivating and studying are the Wisconsin Registry for Alzheimer's Prevention. It's 1,550 people. It was started by Mark Sager back in 2001, and I've got the good fortune of inheriting that cohort when he retired. We have about 81% retention, and among those who are still active, over 10 years of observational follow-up with 3 data collection sites in Milwaukee, La Crosse, and here in Madison. And the home of RAP is at the WAI, the Wisconsin Alzheimer's Institute. In the Alzheimer's Disease Research Center, we created the IMPACT cohort, and the reason for that was that RAP is observational, and we are very interested in prevention, and so we needed a cohort where we could do interventions. And so we created a separate cohort for that, and they're very complementary. Also in the ADRC, of course, we have the traditional groups of mild cognitive impairment and dementia and older controls. The scope of our research at UW on this topic is multifaceted. We're looking at lifestyle and physical activity studies. We're looking at medical comorbidities. We're looking at imaging biomarkers, fluid, genetics, and metabolomics, including the UW 2020 grant that we have, computer science, and other big data approaches to this as well. So here's just a RAP and IMPACT side by side to get an idea of some of the characteristics. Hopefully you can see some of these numbers. We have, at age of entry is 45 to 65 for both of our cohorts, and about 70 to 75% have a parent with Alzheimer's disease, parental family history. And in IMPACT, we have about 420, and RAP 1,500. They started about 8 years apart. The assessments are every other year. Slightly different assessments for cognition, but we get the very similar questionnaires on lifestyle and medical histories and so forth. And they're all aligned with biomarkers as well for MRI and CSF and now PET imaging. We standardize all those things. So the major things we're looking at, of course, is identifying preclinical AD as early as we can, hearkening back to Dr. Kuh's comments, and also identifying those features that may confer resilience or risk to trajectories in Alzheimer's disease. And we're doing these things by looking at tau and amyloid imaging, looking at health and lifestyle factors, looking at how to identify cognitive decline that isn't quite mild cognitive impairment yet, increasing participation in underrepresented groups and enhancing health equity, clinical trial planning, and indeed clinical trials that Dr. Carlson will talk about, and multiple brands of omics, genomics, metabolomics, epigenomics, and so forth. Just to give you a sense of where RAP is now, and IMPACT has very similar characteristics. In terms of the baseline age, it was 54. For IMPACT, it was about 58. If you look at the proportion that are female, 70%, 72% have a parent with AD. About 40% are E4 positive, 9% with diabetes, 31% with high blood pressure are being treated, 50% with high cholesterol are treated, and 37% with a high BMI. Just gives you an idea of the health of the cohort. So let's go back to AD. What is AD? It's a fundamental question, and we know that it's at least amyloid plaques and neurofibrillary tangles. We know that we have potential markers of these things in vivo. We no longer have to wait for death and to look at this disease under a microscope. We can detect this with biomarkers, imaging biomarkers in CSF. Here's the tangles, and here's where they occur. If Dr. Roy was to look at this under the microscope, these are slides from Heiko Brock and the publication from him in 2015 in Brain. showing in dark areas where there's tau deposition. And if you look at the age base rates of tau deposition, and you look at age 70, nearly 90 or over 90% have at least some tau deposition. So this is not just a binary phenomenon. This is something that truly does occur throughout aging. And if you look at amyloid, the same thing occurs. Here's the amyloid stages using the Thal criteria. And here's Brock's criteria. But at age 70, again, at least roughly 40% have at least cortical evidence of amyloid in the brain. So this is not a binary phenomenon. It's certainly a continuum where disease, or symptoms of disease, only manifest after a certain amount of accumulation of disease burden. And what that disease burden is and how it's different from one person to another are things that we just don't know yet. But I'll show you some examples of how we're getting closer. So PET imaging is certainly a way of imaging the burden of amyloid and tau. Amyloid imaging has been around since 2005, tau imaging since 2013. If you look at the PET tracers for amyloid here in the left column, here's a list of currently used tracers. C11PIB is certainly the best of these. It's the first tracer that was discovered, but it's C11 based, carbon 11, which means you have to have a cyclotron and the stars have to align every time you want to use this tracer. As our study coordinators know, you have to schedule the cyclotron and that has to work, and the chemistry has to work, and then of course the scanner time. These other F18 tracers are definitely easier to use, and you can manufacture them at a central site, say in Chicago, and ship them to various destinations. Flutamidamol, florbetapir, florbetaben are all FDA approved. The first of these to get FDA approval was florbetapir. The best of these F18 tracers is NAV4694. It's an AstraZeneca tracer, but it's the one that isn't quite FDA approved yet, even though it's got the best imaging qualities to it. On the tau side, the tracers are T807, also called AV1451, and now called fluortaucipir. This one has the most experience in the field. THK5351 was the runner-up to that until just January of this year, when it was reported that it had some off-target bindings that made it not usable. It's usable, but not quite as useful as we would like, especially in the medial temporal lobe. It's got some off-target binding to monoamine oxidase B. There's other tracers. One's called PBB3. This was developed in Japan, as was the THK5351. Promising new tracers are the Merck compound MK6240, which is one that we are evaluating here, and a new one from Piramal called PI2620. Both of these have been shown to have much less off-target binding and may be more desirable for longitudinal studies and to help us get more specific about what is tau and what isn't tau. Here's some examples of the AV1451. This is from Keith Johnson in Annals of Neurology last year. You can see these areas in pink along this top row, going from a patient who's unaffected to a patient over here on the right who has dementia. You can see how the tau accumulates. And there's also some 3D renderings of tau across the brain in each of these subjects, so you can see the general pattern of accumulation. And here that is again in group findings, in a group setting. Here's an example of the other tracer, the Merck tracer. It's here on the right column. This is a patient with dementia, and you can see the amyloid with the NAV compound on the left and the Merck compound for tau on the right. You can see it binds in the posterior cingulate, and it binds in the temporal parietal areas and the frontal areas. Here's the time activity curves for this Merck compound in this dementia case, and thing to note here is that by 80 minutes, actually more like 60 minutes, we're in a plateau area, and that may be an optimal time to begin imaging with this tracer, 60 to 70 minutes, up to 120 minutes to get a good image. Here's some examples of THK5351, and there's off-target binding in the basal ganglia here. In this top row, we have a 70-year-old who's normal, but has amyloid on this left image. Here's the MRI, and here's their tau image. You can see there's tau occurring in the lateral cortex, and it's less encumbered by the off-target binding in the lateral cortex. And so there's certainly valid tau binding here. And then here's a dementia case on the bottom row. Here's their amyloid, and here's their tau. The MRI isn't that much different. There's certainly more atrophy, especially in the convexity, but the hippocampus isn't out of range for normal aging. So getting back to preclinical AD and staging of risk, there's been a couple of frameworks for how we can stage risk. One is from the Alzheimer's Association and NIA in 2011. They had 3 stages: 0, no pathology; 1 is amyloid; 2 is amyloid plus some form of neurodegeneration, including tau; and 3 is mild cognitive decline. And then there's another phase, it's called SNAP, suspected non-Alzheimer's pathology, where you've got tau only in the absence of amyloid. And then there's the Dubois criteria. These are, some think of these as the European criteria. I don't know if that will work or not. Anyway, there's 2 major frameworks here. One is asymptomatic at risk, where you have tau or amyloid, or preclinical AD, where you have tau and amyloid. And so those are the 2 commonly used staging systems. Now, we have applied this to our group here using the spinal fluid that Dr. Carlson has collected on many, many people. And this is work from Lindsay Clark, and this is under review right now. We had 315 people, roughly, who had spinal fluid, who were either in impact or RAP. And we just staged them, or put them in different groups according to their CSF pattern. And most of the subjects were negative, but about 30% had some form of amyloid or tau or both. And this is at age, at the time of LP, age 64, 62, 65 for these different groups. This group is amyloid positive, but tau negative. And then we have tau positive, or the SNAP group here, and then the group that has amyloid and tau. And this would be our preclinical AD group. You can see that they differ at baseline in their age. The amyloid plus tau group tended to be a little older. They were certainly more likely to be E4 ApoE carriers than the other groups. And these are their cognitive baseline effects. There really wasn't much different between them in terms of their baseline cognition. But if you look over time, we can see that the amyloid positive, tau positive group, which is kind of the greenish group, they are more likely to show a steeper longitudinal trajectory of their cognition. And this is across all of the different memory tests that we looked at. This replicates prior work that Lindsay has done, where we looked at amyloid imaging with Pittsburgh compound B, and we found that the people who had higher amyloid tended to decline faster. So what about the effect of amyloid and tau on these modifiable risks that I mentioned earlier? Here's some correlations that have been published from our group on this one on the left, looking at sleep. This is the second study from Kate Sprecher in Barb Benlin's group to show that markers of AD correspond with sleep difficulty. In this case, it's tau over A beta 42 in the spinal fluid shows a correlation with various measures of sleep function. Here I've looked at, I've just displayed sleep adequacy, but we have other measures as well where there's strong correlations. Here's one from Dr. Okonkwo's group showing the effect of amyloid on age among people who have an active lifestyle versus an inactive lifestyle. And the people who are inactive as a group show the characteristic age increase in amyloid, whereas the people who have an active lifestyle show a flatter, more age-protected slope over time. And this is looking at insulin resistance here on the right, and glucose uptake is the y-axis, and insulin resistance is the x-axis. And we find a strong correlation there. A very similar finding is seen with amyloid. And here's some new data that, again, Dr. Clark has worked up together with Rebecca Kosick, again, looking at health behaviors and the impact of biomarker positivity potentially on these behaviors. This is all associational data, so we can't really infer causation, but what we did here was we have an amyloid positive group that is hypertensive, an amyloid negative group that is hypertensive, and then amyloid positive without hypertensive, amyloid negative that's not hypertensive. And we plotted the cognitive trajectories over many years, and we see that the amyloid positive group that is hypertensive has the steepest rate of cognitive decline. And we observed that as well for looking at the same framework with obesity. The amyloid positives who are obese have the steepest rate of decline. If we look at cognitive activities, the amyloid positives who are not engaged in cognitive activities by their own self-report are showing declines in cognition, whereas the other groups are showing what we often see in our cohorts is somewhat of a familiarity effect or practice effect as they take the same tests over and over again every couple of years. So what is it about all these things that may be conferring greater risk? Is this truly just epiphenomenal and correlational, or is there something here that we can investigate further? We think one thing that they may have in common is a relationship with vascular health. And so we are looking at that using techniques developed here at UW with the idea that vascular pathology may confer vessel stiffness, and that may cause a reduction in the brain's ability to clear some of these metabolites like amyloid from the brain. So we're using this technique that was developed here. It's called PCVIPR, and you can not only get a nice angiogram, but you can get cardiac-gated and cardiac-linked understanding of the dynamics of vessel flow in these major cerebral arteries. And this is looking at the internal carotid artery, and you can see the heartbeats and the flow going through, and we can measure how this is related to vessel stiffness and flow and volume and several other parameters of vessel health. We've published a number of papers on these with our initial validation experiments across our ADRC, and we indeed show that patients with dementia, which is presumed to be due to AD in our center, have stiffer vessels than people who are younger or who are healthy controls. And that's across the arteries as well as some of the major venous systems that we've studied. Same thing with blood flow. The amount of blood going through the brain is decreased with greater symptoms. And another very interesting thing we've been looking at is the transit time between the arterial side and the venous side. And it's also the case that the patients who have more symptomology show a faster transit time of blood going through from the arterial side to the venous side. This means, even though we don't have the resolution to study at the capillary level, the inference is that we're not getting quality perfusion at the capillary level. We're likely getting a high degree of pulse pressure at the capillary level, causing microvascular hemorrhages, causing tortuosities, and decreasing the efficiency of the vessels at the capillary level. So this is work from Sarah Berman, looking at the internal carotid artery mean flow against people who are amyloid negative and amyloid positive, and the amyloid positives have lower mean flow, and these are all MCI participants. So all of these things together are telling us that, that vascular disease may be a bigger piece of this early on than the current framework of the Alzheimer's disease biomarker continuum. So these are things that we're investigating. These are things that need to be followed up with clinical trials or prevention trials to potentially look at some of these things as therapeutic targets. More work will need to be done before we settle on which, if any, of these we would want to use, but we think these are important signals to follow up on and certainly not ignore. Let me just conclude by saying that we can identify AD in vivo, in life, and we think that around age 60, about 20 to 25% have some form of AD pathology, and by age 65, about 30% have some form of AD pathology. We need to learn who with this pathology will go on to get symptoms. Not everyone will. We know that about 40% of people we know that amyloid can be asymptomatic, at least, in about 40% of people. Why that is something we don't know, but we think it may be due to some of these things I just showed you about things that improve one's resilience to this disease. And finally, we need to obtain the endpoint phenotypes captured by conversion events. So we need to know, that means we need to know who converts to dementia and who converts to MCI so that we can then look back at their earlier observations and their early biomarkers and see what we can learn from those early time points about what it might be that predicts who's going to go on to develop those symptoms. I'll stop there by acknowledging all the many people who are part of these endeavors, and this is most likely a partial list because this is such an involved set of endeavors and so many interwoven entities and grants and institutes, but I want to thank everybody who's been involved in these things. I'll stop there.